Worldwide, there are currently about 3.2 million children HIV infected. Most of these children are perinatally HIV infected. Since about 1996, there is a potent combination antiretroviral treatment available, which has proven to be very effective in reducing both mortality and morbidity of perinatally HIV infected children. But despite the potent effect of CART, important neurocognitive impairments and dysfunctions are apparent in these children. These dysfunctions consist of neurocognitive impairments such as learning disorders, language disorder, motor disorders, and a lower IQ. The pathogenesis of this HIV-associated cerebral injuries is unknown, but we think that it is importantly different than the pathogenesis in adults, as the brain of the child is still at a developing stage. The same holds true for the immune system, which takes a couple of years to develop until a full mature state. There are possibly three mechanisms underlying the cerebral injury that we find in HIV-infected children. First of all is direct injury from HIV itself. The second is due to the chronic neuroinflammation of an HIV infection. And lastly, the direct toxic effects of a lifelong CART.
The resulting cerebral injury is evident in neuroimaging and laboratory investigations. Neuronal loss or impaired brain growth is visible on MRI scans as reduced grey matter or white matter volume. In adults, we also see increased neuronal damage markers in cerebrospinal fluid. Injury to myelin and axons can become visible as white matter lesions throughout the brain. But even when the white matter looks normal, MRI techniques such as diffusion tensor imaging and magnetic resonance spectroscopy detect microstructural white matter injury in HIV-infected children with neurocognitive impairment. Something that may be important in the long run is the potential for HIV to damage blood vessels. Perinatally HIV-infected children have increased endothelial activation and inflammation markers in the blood, as well as early signs of structural and functional vascular changes. Even though treatment with CART, especially early in life, results in much better outcomes, some antiretrovirals are associated with neurotoxic or metabolic side effects.
In conclusion, perinatally HIV-infected children that are being treated with CART are still at increased risk for neurocognitive impairment and cerebral injury. The pathogenesis remains unknown, and there are many questions to be answered in the future. Future research should therefore focus on the following items: age-specific immune responses within the brain of these children, and also to optimize CART treatment in these children, studies should focus on the protective or toxic effects of CART in this specific population. The detection or monitoring of cerebral injury with neuroimaging to detect early subclinical macro and microstructural changes should be evaluated on the long term. And by evaluating inflammatory, neurological, vascular, pharmacological, and virological markers, one can increase our understanding in the pathogenesis of HIV-associated cerebral injury. And lastly, longitudinal studies are needed to evaluate the long-term effect of lifelong HIV infection and lifelong CART as these children survive into adulthood.